We are live.
Good evening, everyone. Welcome to the iFocus online lecture 423 of the Cataract module. Today, the topic of class is iris repair techniques. For the session, I would like to introduce the moderator, sir, Dr. Prafulla, sir. He's finished his MD senior residency from RPC AIMS New Delhi. Sir is an additional professor at RP Center AIMS New Delhi. He's also the current secretary of DOS, Delhi Ophthalmic Society. Sir is the chief editor of Ophthalmology Clinics, Ophthalmology Clinics 2, and Postgraduate Ophthalmology book series. Sir has published over 395 and 156 indexed papers and more than 50 chapters in national and international books. Sir has also won Best Surgical Technique Award from RANSCO, Young Achiever Award at ISCKRS, Dr. Ajit Babu Maji Award, and awards for Best Paper at various conferences. Sir is also the principal investigator in 2 ICMR trials, co-PI in 18 trials, including 2 multicentric international trials. Welcome, sir.
Thank you, Garvita.
I would also like to introduce the chairperson, sir, for today, Brigadier Dr. Gaurav Kapoor, sir. He's the professor and HOD in ophthalmology from AFMC Pune. Sir is trained in refractive surgery. He's won multiple awards and honors. He was the first in grading exam in 2003. Sir has been the Chief of Army Staff Commendation 2014, second in MOSCC in 2016, more than 30 international and national publications. Sir has been a winner of second best article at MJAFI in 2014, best AFMRC project in 2014, best innovation award in 2019. Also the BPOS in Cataract for AIOC to 2020. Sir is also the winner of Think Under the Apple Tree winner into AIOC 2020. Sir is also a patent holder for angle chopper and dialer, also the examiner for MBE, GGS IP, MUHS, PGIMS, Rohtak. Welcome, sir, for today's session.
Thank you, Dr. Garvita. Great to be part of this session.
Thank you, sir. I would finally like to introduce the speaker of the session, Dr. Obuli Ramachandran, sir. Sir has finished his MD from AIMS, FVRS from Arvind Eye Hospital, MRCS and FICO and FIPO in Retina. Sir is currently working as Associate Consultant in Center for Sight New Delhi at Safdarjung, Dwarka and Agra Center from 2021 onwards. He has qualified his MD from AIMS New Delhi, also completed fellowship at Arvind Eye Hospital, Madurai in vitro-retina from 2017 and 19, where he was also a retina consultant. Sir has published more than 15 papers in various national and international journals. Sir has also won the Best Video Award in OPL 2022 at AIOC Kochi. Sir also has been awarded the Best Video Award in Asia Pacific Vitro-Retina Society Conference held in Hong Kong, November 2023. Sir has also presented various papers, videos, and posters at multiple international conferences. Welcome, sir.
Thank you, Garvita.
I would like to welcome Dr. Obuli, sir, to share his screen for the class, sir.
Yes. Am I audible? Are my slides visible?
Yes, sir.
So, good evening, everyone. The topic for today is iris repair techniques. I'm Dr. Obuli Ramachandran. Now coming to the first, just a second. Why is this thing not going? Yeah, slide control. Yeah. So, coming to the prologue, iris defects or pupillary decentration not only impairs vision, but the quality of life also. Patient complain of varying degrees of photic symptoms. Even after a good cataract surgery, a small iris defect can actually cause a lot of detriment to the patient and can contribute to the lot of one more unhappy patient. Iris defect should be acknowledged and the need for addressing should be good. Now, before we start about the repair of iris, we need to start the anatomy of iris. So coming to the anatomy of iris is the anterior-most part of the uvea. It is a network of connective tissues, blood vessels, and melanocytes. Collagen fibrils of hyaluronic acid create the stroma of iris and provide elasticity. Stroma contain multiple crypts to allow the passage of aqueous humor into the anterior chamber. Vascular network comprises of major and minor arterial circles. Coming to this diagram, you can see that this is a beautiful diagram about the multiple structures of the iris. The thing which we are in this today's topic, what we are going to see is the pupillary portion and the ciliary portion, which are the part of the irises which actually cause most of the problem to the patients. And also, we need to keep in mind the structures E and F, which are the major and minor arterial circles, while suturing the iris, because if at all you inadvertently cause trauma to it, you can cause hyphema to the patient. Iris defects can be congenital or acquired. Congenital, like hereditary conditions like iris coloboma, ICE syndrome, Axenfeld-Rieger syndrome. Acquired, like iatrogenic, like surgical removal during any procedure. Traumatic, like penetrating wounds. Complicated intraocular surgery like dialysis, trauma to the sphincters leading to atonic pupil. High-risk patients for iris defects are people who are having a predisposition to intraoperative floppy iris syndrome or IFIS syndrome. People who are taking drugs like tamsulosin, you should be wary of IFIS. Also, people who are having pseudo-exfoliation syndrome or people who are having a history of iritis. Types of acquired iris defects. Trauma to the iris can present in various ways depending on the location and severity. They can appear as tears at the pupillary border, tears at the root of iris. Tears can be divided upon the thickness of iris tissue involved, full thickness through the iris stroma, partial thickness involving only the posterior pigment epithelium leading to transillumination defects. Now coming to the mydriatic or atonic people, they can be because of two causes. One is tears of the pupillary border. This can happen post blunt trauma. There can be multiple sphincter tears, pupillary margin tears causing an atonic pupil, or there can be a damage to the sphincter muscle. And iridodialysis, they can happen because of tears at the root of iris or disinsertion of the iris, either complete or partial. Clinical presentation, a well-centered pupil is of optimum size is needed for the best vision. Otherwise, the patient can present with the following set of symptoms: glare, photophobia, colored halos, difficulty in near work, and double vision. Indications for repair, functional or optical indications, iris defect leading to photic symptoms like glare, halos around the light, near vision problems, and double vision can be considered for surgical intervention. Also to provide structural support for lens implantation. Earlier, when there was only ACIOL, sometimes pupilloplasty was done to provide the necessary support for either the ACIOL or for iris claw as an option if there was no adequate capsular bag support to implant the IOL inside the bag. Indications for repair, there are other secondary indications like to prevent postoperative complications as in PKP. Post-penetrating keratoplasty, sometimes there might be an addition of the iris to the graft. To prevent that, sometimes pupilloplasty is done to prevent the pus formation and a secondary glaucoma also. And also to relieve the oppositional angle closure or pus. Pupilloplasty can be used to break the pus in post-trauma, in plateau iris syndrome, in Urred-Zavalia syndrome, and in cases associated with long-standing silicone oil in the anterior chamber. To provide more cosmetically acceptable people, this seems to be the most common indication because especially in large colobomas or colored iris, it can provide functional and cosmetic repair. Relative contraindications for repair: phakic eye with clear lens due to the possibility of lens stretch and cataract formation, and atrophic iris due to the possibility of iridodialysis and increased iris damage because the suture will not engage the iris if it is very atrophic in nature. Types of iris repair surgeries: surgical and non-surgical. Surgical involves two major types, pupilloplasty and iridodialysis repair. The non-surgical involves laser procedures. Types of pupilloplasty. The most common or the earliest form is the Seeps or sliding knot technique. There are other techniques like pupillary circlage technique, single pass fourth row technique, and pinhole pupilloplasty. Now coming to each one of these techniques in detail, the Seeps or sliding knot technique involves a paracentesis created at 10 o'clock and 2 o'clock position. 10-0 propylene is passed through the proximal and it is engaged via 26 needle at the distal end and it is brought out. And then the distal end of the iris, the suture is brought out through the proximal forming a loop. and then 3 or 4 passes is made through this loop, and then both the sutures are pulled on either side, causing a knot in the center, and that causes the closure of it. Now coming to the pupillary cerclage technique, the needle with 10-0 polypropylene is passed in and out through the AC through the limbal paracentesis openings. The needle is crisscrossed through the iris near the pupillary margin to form cerclage. Both suture ends are exteriorized at the last paracentesis and tied with a sliding knot. The suture ends are cut with a microvenous scissors. This causes a perfectly round pupil, but it involves multiple punctures of the iris and can cause iris pigment dispersion also. Single pass fourth row technique. This technique was popularized by Dr. Amar Agarwal. And this technique is very much similar to the Seepser sliding knot technique. In this, what you need to know is after docking of the 90 polypropylene and bringing out through the distal end, you divide the segments of the suture into 5 parts. And what you need to do is basically bring the part 2 via the proximal end and make a loop, and then you cut the proximal side of the suture, pass it through the loop for 4 times, and then you pull the loop on either ends, and then what you end up is having a knot at the center. The last one is pinhole pupilloplasty. This is again done for patients who are having traumatic atonic pupil, whereby we do the Seepser knot technique on either ends, the superior as well as the inferior end, causing a pinhole at the center. This is for people who complain of much of glare or photophobia, especially in post-traumatic patients. Now coming to the types of iridodialysis repair, the different types of techniques are mechanical technique, hangback technique, sewing machine technique, cobbler technique, stroke and dock technique. Mechanical technique involves a polypropylene suture passed through 2 paracentesis through both leaflets of the pupillary defect. A hook is introduced through the stab incision and is used to bring both the ends of the suture out of the eye, and the ends are tied outside and to close the defect. Hangback technique is the most common technique. In this technique, what we do is we first create a scleral tunnel parallel just outside the limbus. And then we make a paracentesis, pass the 90 proline and engage the root of the iris, and then bring the one end of the needle out through the scleral tunnel. And then the second end of the 90 proline is also, taken in a similar way, 1 or 2 mm away from the first entry. And then that is also externalized through the scleral tunnel. Both the ends of the needle are cut, and then the knot is formed outside. And then this knot is then internalized, and the overlying scleral tunnel is closed. And this leads to the closure of the iridodialysis. The second technique is a sewing machine technique. Sewing machine technique involves threading of the 10-0 polypropylene sutures. The suture is passed through the peripheral iris and exteriorized through the partial thickness scleral tunnel. Suture loop is created by withdrawing the needle in anterior chamber with an assistant holding on to the exteriorized suture. The same process is created to create multiple loops. And then each loop is then tightened. And by this thing, what you prevent is the peripheral small iris defects, which can happen if you do just the hangback technique. Cobbler technique is again a variation of this. In this, a 10-0 polypropylene is threaded through 20 needle. The suture is passed through the peripheral iris and exteriorized through the partial thickness scleral tunnel. The suture is pulled out, forming a loop through which the free end of the suture is passed to lock the loop. This step is repeated multiple times until multiple loops are laid over the scleral bed. The first suture is end which has been passed through the loops is then tied with the other end, and while you tie, you can see that the iris is beautifully opposing towards the periphery. Stroke and dog technique is again a variation of this, whereby which is used for a very large iridodialysis, at least 6 clock hours. In this, first of all, you take a 20 needle and then you stroke the iris towards the periphery, because when the iridodialysis is more than 6 clock hours, the iris sometimes crumples towards the center of the eye. So what you do is you first stroke the iris towards the periphery, and then you dock it, and then you bring it out, externalize it, and then using the hangback technique, you suture it off. And then because the iridodialysis is so big, you do multiple such scleral pockets and multiple such sutures, so that almost the entire iris is opposed. Now coming to the non-surgical technique, which is the laser technique, organ laser pupilloplasty. Organ laser pupilloplasty can be used to adjust the position of the decentered pupil, change the size of myosed pupil. The procedure is performed by applying laser spots to the mid-peripheral iris in a sectoral fashion to pull the pupil in a particular direction, which is mainly aimed for correctopia for recentration of the pupil. Argon laser pupilloplasty may also be used in combination with other procedures like argon laser peripheral iridoplasty to relieve the pupillary block. Now coming to some of the surgical techniques, we have been seeing theory till now. If we see some surgical videos, it will be easier for people to understand as to what each technique is. The first case is a case of IOL edge effect. There is a traumatic subluxated cataract with a mid-dilated pupil. A cataract surgery was done, but because of the subluxated cataract, the lens post-surgery was not centered. And as you can see in this, because of the mid-dilated pupil also, there is an edge defect which is forming. The best corrected visual acuity was 6.6, but the patient presented with glare photophobia, colored halos, difficulty in day-to-day activities. Coming to the first video, you can see the technique. What we are going to use is a single pass fourth row pupilloplasty. Through the proximal paracentesis, a straight 90 proline is passed. And then through the distal end, a 26 gauge needle is taken and the needle is docked and it is externalized. After the externalization, the distal end of the suture is grabbed by a help of the forceps and it is brought out through the proximal paracentesis, and then the proximal suture is cut right now, and as 4 rows are being made, and now both the ends of the suture are pulled in either direction through both the paracentesis, and while you are pulling, you can see that the knots are going in center and it is falling perfectly over the iris, and at the end of the surgery you get a nice circular pupil. So this was a post-operative. There is a round pupil and there is a reduced symptom of the edge defect and the reduced glare for the patient. Now coming to the second case, this is a history of a blunt trauma with a history of operated retinal detachment. During the primary surgery, the patient had a ruptured nucleus and the nucleus was extracted along with the primary surgery and silicone oil was placed. And because of the trauma, you can see that the iris is extremely irregular in size. And also there is right now the patient is having aphakia with multiple sphincter tears and emulsified oil in the AC. We had planned for a simultaneous scleral fixated IOL. So after the infusion, you can we made an AC keratometry and the oil was expressed out through the anterior chamber. After the removal of the silicone oil, by the handshake technique, through the scleral pockets made for the haptics, we are externalizing the leading haptic out and we are bringing it out through the scleral pocket. And after that, the trailing haptic is also externalized through the other scleral pocket and they are tucked. Now, after tucking the IOL, you can see that inferiorly there is a large area of aphakic area which can cause very severe symptoms for the patient. So we decide to go ahead with the pupilloplasty. The technique is the similar sliding knot technique, which is a variation of single pass fourth row technique. The distal end is made into a loop and it is brought out, and then the proximal end of the suture is then made into 4 rows, and then the distal end is engaged, and after engaging, both the ends are externalized through either paracentesis, and the knot is cut with the help of macrovenous, and after that the scleral tunnel is closed with the help of the glue. Post surgery, you can see that the IOL is also well centered, the round central pupil is also there, and the patient developed had an optimal vision gain. Now coming to case 3. Case 3 is a traumatic iridodialysis with secondary cataract. The patient was a young male with a history of blunt trauma with a ball. The patient developed traumatic cataract with iridodialysis. The retina was fortunately okay, and an attempt was tried to give the best possible vision. Because the patient had a blunt trauma, we had suspected some zonular dialysis also. So we went ahead and planned with a femtosecond LASIK cataract surgery. After the femto cataract was done, we realized that the bag was intact and the bag was stable. So we went ahead and placed a single piece IOL in the bag. After the placement of the IOL, and we put a pilo in the AC, and after pilo, you realize that there is a 2 clock over superior iridodialysis. So the technique was the hangback technique, whereby we made a scleral tunnel, and one end of the 90 prolene is engaged to the root of the iris, and it is externalized. After the externalization of the first one, the second, the other end of the 90 prolene is also brought in through the paracentesis. The root of the iris is engaged, and that is also externalized. And after the externalization of both the ends, we cut the ends of the needle, and then end-to-end suture was done. And after the knot formation, you can see that the iris had gone to the periphery very quite beautifully. And what you get is a nice round central circular pupil. And the tunnel and the conjunctiva was closed with the help of a glue. Coming to the last case, this is a case of traumatic iridodialysis with IOP spike and clear lens. The patient had a history of blunt trauma, and because of which the patient developed almost 6 clock hours of iridodialysis. Apart from that, the patient also developed a traumatic secondary glaucoma. The patient presented to us with IOP of over 50 millimeter mercury, and after maximal AGMs and mannitol, also the pressure remained around 30 to 35 mm. So hence we decided the best case course is to go for an Ahmed glaucoma wall along with the iridodialysis repair. The technique what we used was a stroke and dock technique. Because of such a big iridodialysis, first thing you need to do is you need to put a viscodispersive, a viscoelastic in the AC to push the iris back towards the periphery. This is also done to prevent any trauma, potential trauma to the lens, because it creates a plane between the iris and the lens. So because the iridodialysis was so huge, we planned for multiple scleral tunnels. So the technique is the same hangback technique. We externalize one end of the 90 prolane out, and the other end is also externalized. And once you externalize both the ends and the external knot is applied, you can see around 2 to 3 clock hours of the iridodialysis getting opposed. Still, there are around 1 to 2 clock hours of iridodialysis left. So we made another hangback or another scleral tunnel temporally. The same technique was repeated. And at the end of it, you can see almost a near circular or an oval shaped pupil. But the most important thing is that the iris went back to its position. The patient at least has a functional pupil. And then the patient was proceeded for the Ahmed glaucoma wall surgery, which went successfully. So the patient, this was the pre-op and this was the post-operatively. You can see that the IOP was normal, the pupil was centered, and the AGV was also in situ. And all of this was done without touching the lens. So that concludes my presentation. Thank you. I would like to convey my regards to my fellow Dr. Shweta and my senior consultant, Dr. Amnendra Gupta, for the videos. Thank you all. And now the session is open for discussion.
Thank you, sir. That was a lovely class that described all the methods of iris repair very beautifully. The videos were also very excellent. I want to invite Dr. Gaurav, sir, our chairperson, sir, for his expert comments, sir.
Thank you. Dr. Obuli covered all the available techniques and all the methods to repair the pupil. An excellent presentation. And I just had a comment. Can you, any of these techniques help us in titrating the pupil size so that there is a pupil matching between the two eyes? Is that possible in any of these techniques?
So the basic thing is basically the technique which closely resembles your query is the pinhole technique.
Encerclage.
The encerclage or the pinhole technique. Encerclage involves multiple puncture wounds, and that causes in the hands of untrained person, it causes a lot of pigment dispersion. So the best thing is pinhole, whereby you take a photo of the other eye, you just measure the pupillary diameter, and then on table, if you have a microscope whereby you can measure it, you can do a pinhole by superior and inferior and try to make it as close as possible. But nothing can give exactly.
Exact
You can
results.
just try your best. Yeah.
With large defects or maybe central defects, any of these patients followed up, do you see a difference in the scotopic and the photopic pupillary sizes? There is a change in the contraction of the pupil.
Yes, sir. So basically, what we are trying to achieve is for the photopic.
Reduce photophobia and glare. Yeah.
Yes, yes, yes. The pupil is never going to function back again to normal how
Yeah.
it used to be, and we need to explain to them clearly that there will be some trade-offs post surgery also. Like the patient, we will try to solve one thing, but by that we will be causing some new problem also, like then and a reduced night vision or other stuff, which we need to explain to the patient, clearly pre-surgery. And yeah, there is nothing which makes us like exactly a normal functioning pupil, but this is majorly for the glare and the photophobia and the halos,
Yeah,
because
probably the pupil responds better in cases where there is a peripheral iridodialysis. There
yes,
may be some amount of pupillary contraction does come back, depending
any
on
amount
how
of
long
blunt,
the and how old the injury is, and maybe how atrophic the iris. Because long-standing injuries,
yes, sir.
I think you have a iris which would tend to be atrophic in sectors, and the muscle would have also atrophied because of non-functioning.
Yes, sir.
So to achieve
Basically
perfect
blunt
functionality
trauma.
is not possible.
Yes, the blunt trauma actually causes the most common organ to get injured is the sphincter or the
Sphincter muscle. Yeah,
sphincter
that's true.
muscle. So most of the times you
Any
get an
tears, they
atonic
do
pupil.
not get repaired. They do not
Yes,
heal.
you get an atonic pupil. You try to
Yeah.
manage the best of the situation. You tell to them, because if you go ahead hastily and do a smaller pupil, and then the patient, God forbid, develops retinal pathology, even the retina surgery becomes difficult. You again have to try to do the surgery through a smaller pupil. So all of these are trade-offs you to do. So you have to, the patient selection is also very important. You need to do a thorough retinal evaluation. You have to explain to the patient that in future a retina surgery happens, then we might have to open up the knot to give us a better visualization. So a lot of things are involved, and patient counseling and patient selection is the most important, sir.
Yeah. One last query or comment. A
Yes, sir.
lot of these patients with extensive iridodialysis and say maybe a normal IOP,
Yes, sir.
uh, post repair, have you seen spikes in the IOP? Because you cannot actually control or titrate where the sutures have gone through in the angle. So any patients with high IOP post-op, maybe 3 to 6 months after the iris repair.
Trauma is a spectrum, sir, whereby the moment the iridodialysis happens, you have a crushing of the angles.
Of
The
the
moment angle crushes, there both the things are interconnected. So even whether you operate or not, invariably all of these patients end up in secondary traumatic glaucoma.
and
So that is the secondary open angle glaucoma because of the crushing of the
but
angle. So I
yeah.
explained to them that you have to come for routine follow-up, because immediately it may not happen, but 3 or 6 months down the line, most of these patients end up in secondary glaucoma, and they most of them end up in needing to have a valve only, because
Glaucoma
even
surgery later on.
yeah.
Yeah. Uh, can we move on to the questions now? Is there any questions from the participants? I think there are certain questions which are popping up. If we can take them one by one.
Yes.
Yes, I'll just ask these questions. First question is, sir, what is the preferred technique in case of iridodialysis post SICS?
So, iridodialysis post SICS, you need to identify first where the tunnel you have made is and where the iridodialysis has happened. If the iridodialysis has happened below where the tunnel is, then making a new scleral tunnel will become very difficult. Then you will have to plan the surgery in such a way for the first the tunnel pre-existing SICS tunnel to heal before you plan for a secondary procedure, because any technique involves you planning trying to hook the iris towards the end of that or towards the area of the limbus where it has got detached. So that is the major thing you have to take up. So if the patient is early post SICS, you have an iridodialysis, I would wait for the previous tunnel to heal before I plan for the iridodialysis repair, because iridodialysis repair can happen at a later date also. It doesn't need to be repaired immediately, but going in too early, you can sometimes reopen the tunnel, or you can cause an angle bleed, or vitreous cavity bleed also.
Right, sir. Second question is, what are the post-op medications that need to be given for how long, sir? Like pilocarpine or brimonidine, which is also preferable, sir.
I would not give pilocarpine post-operatively. On table, I will definitely use it to see how much it contracts, and that will give me an idea of the pupil size. But pilocarpine causes inflammation. So I would give it on table, and after that, I would give them maximal steroids, because you are meddling with an organ which has a lot of pigments in it. So the moment you meddle with it, there will be a lot of pigment dispersion. There will be a lot of pigments over the lens or eye oval, and it can also cause a lot of inflammation because of the pigment release. So I would ideally keep the patient on an hourly or 2 hourly steroids, and I would like to give them as one anti-glaucoma medication, single anti-glaucoma medication, not a combination, and then see post-operatively where the IOP comes before I titrate or add more. You give a lot of anti-glaucoma medications and the globe becomes soft, and that leads to hyphema, or more pigment dispersion happening. So all of the initially the most important thing is steroids. And if the patient is non-diabetic, I would also add an oral steroid just to reduce the initial intense inflammation. And after the inflammation subsides, then probably I would reduce the steroids and then look for the anti-glaucoma medications what to give.
What if the patient is a steroid responder, sir? Just a question from my
Yeah,
side.
Kavita, can I just come in?
yeah, yes, sir, please.
Acha, Obuli, thank you for that wonderful talk.
Yes, sir.
And just a continuity to this question, that's why I
Yes, sir.
interjected.
Yes, sir.
So when you said steroid, you are going to give it 1 early or 2 early. Is it
Yes, sir.
routinely you prefer, or is it the day one post of finding? Because at times, in clean cases, especially post-traumatic cases, 4 months, 6 months later,
Yes, sir.
when you do a pupilloplasty, the reaction
Yes,
is not that much. So
yes,
do
sir.
you routinely give 1 early from day one, or you would like to see the day one post-op?
First 3 days I
That
give
is
2 hourly, sir.
one. And second,
First 3 days I give 2 hour.
oral steroid
Hello, sir.
important because this is hello.
Yes, sir. Please tell me.
Am I audible? So,
Yes, sir.
how
Yes, sir.
long? Because for students, it's very
Ye-
important to know
Yes, sir.
when to taper and how to taper after
Yes, sir.
iridodialysis or any iris repair procedure.
Yes,
So,
sir.
could you just explain to them how long steroid should be given and how to taper
Yes,
it
sir.
off?
Yes, sir. So, the cases I operate, I am very worried about the initial inflammation. So, 1 hourly or 2 hourly steroids I give for the first 3 days, and then based on the response and how quickly the patient becomes quiet in the AC wise, then I taper it quite quickly also. So the patient is initially started for 2 hourly for the first 3 days, and then if I feel that the AC is quite, like you said, a long-term iridodialysis which I've operated, the AC has become quiet, then I taper it down to 6 times, and then every fourth day I reduce it and I give a quick taper of steroids. And coming to the oral steroids I only give in early interventions. Now the cases where you have mentioned, like old iridodialysis, which we accidentally found out, which we are operating along with some scleral fixated IOL procedure or any other thing, I don't generally give oral steroids that much. This is only for the immediate trauma patients who I expect a lot of inflammation. Those patients I give oral steroids, and even oral steroids, I don't give them like 1 milligram per kg body weight. I give a 0.5 milligram per kg body weight just as a support adjunct to the topical therapy. And that also I quickly titrate it, like 5 days, 5 days titration. I reduce the oral steroids also.
And one more, specifically for PG exam, I'm asking this.
Yes, sir.
So, is there any type of iris or anything when once present you will avoid during iris repair? And if you are avoiding iris repair, so what are the alternatives to that
Sir, you can put segments also. Nowadays,
for
there
any
are
surgeon?
segments there which are there, which you can, for example, a patient who is having a congenital iris, the IFC, irid of fundal coloboma, there is an inferior iris defect. Instead of doing a repair, you can put a segment there which can mimic like an iris, and that will create a nice rounded pupil. And as regards to people as to whom to avoid, pigment dispersion syndrome people I would avoid, because the iris will already be pretty flimsy. And also in patients who are having the pseudo exfoliation syndrome, the iris is pretty fragile. These are the patients I would avoid doing any iris repair surgeries.
Even in
Also, old
atrophic iris.
iris.
Yes, sir.
If I may intervene,
Yes, sir.
iris
Yes, sir. Yes, sir.
segments. Yeah, a lot of these patients where you have, even in traumatic cases where you have large segments of iris loss, so rather than going in for an iris repair where you wouldn't be able to achieve the desired outcome, an iris segment is obviously better.
Yes,
So
sir.
where you have large segments missing, maybe more than 4 clock hours, 3 to 4 clock hours, rather than attempting maybe a full sector missing,
Yes.
sectoral defect. There a segment is obviously better. There you shouldn't go in for a repair because it will be technically difficult and you won't have the exact outcomes that you desire. The pupil size, maybe the glare halo photophobia, because you will still have a secondary defect in the periphery, which may you may complicate the issue by causing diplopia, which was not present earlier
Yes, sir. Yes.
in large defects, only in large. So
Also,
an iris segment is even better in such cases.
yes. And for students, I would just like to add here, examiner may maybe eager to ask you, suppose you cannot do iris repair, what are the other options? You can always have a tinted contact lens or corneal tattooing. If the patient is having glare and you are not
Hmm.
able to repair it, these are also the options if you don't want to person glaucoma. If you, in gonioscopy, if you find a heavily pigmented trabecular mesh, in all the situation when you don't have a choice to do pupilloplasty or iridodialysis repair, there you can do customized tattooing or customized tinted contact lenses to avoid this glare, diplopia, all the symptoms. Garbita, do you have any more questions?
Yes, sir, we have a lot of questions on YouTube, sir. First is, what should be done if you do pupilloplasty
Yeah,
and a triangular defect is remaining,
please
which
go
is
through
big
that.
and causes polyporia sort of situation? So, I think.
If there is a peripheral small defect, it shouldn't cause
Yeah,
that
Obuli, would you
much
like
of
to
a
take that?
polyporia.
Yeah.
Sir, you want to ask this, sir?
Polychoria, if polychoria, it can cause, but whoever the student is, first you have to check where is it. For example, suppose it is exactly opposite the upper lid, so it's not going to bother the patient that much. But if it is in temporal quadrant or
Temporal and
inferior
inferior
nasal
defects are
quadrant, where
going
the
to be
comes into
problematic.
play, and there may be problem if yeah. So in
Ideally,
those
you should,
cases, if you can
yeah.
repair, as Obuli showed you a lot of videos, you can do that. If that is not possible, as we discussed just now, do a sectoral, either iris segment. If
Iris
that is not
segment.
possible, do a tattooing or give him a contact lens. Yeah, anything like that you can do.
I
But
think
you'll
that
have to
would
repair
be
if
a
it is
simple and
causing
best
polychoria.
solution. Yes, sir.
Yeah.
It's, so next question is, in the last case, sir, when you repaired iridodialysis, you end up with a large pupil. So what can you do for that, sir?
Too much of intervention together is also not good. The major thing in that was to first make the iris go to where it was rather than it was crumpled at the beginning, and to reduce the pressure. So after the intraocular pressure got reduced, probably down the line you first evaluate how good the patient's vision is, because the patient presented to us with 1/60 because of traumatic optic neuropathy also. So if the patient improved post surgery, then down the line, you can plan for a simple pinhole pupilloplasty also to reduce the size of the pupil. But that could be at a later date. Right now, the first aim was to just ensure that the pupil goes back. And that also helps because we had planned an Ahmad glaucoma valve. If we hadn't planned the pupilloplasty, there is a risk of vitreous also coming to the ACA and clogging it. So that's why we had to do this amount of iridodialysis repair along with the AGV.
Right, sir.
And normally, such patients, they do not have problem. I don't know what is the reason. When we do iridodialysis repair,
Yeah.
very rarely patient complains you of glares or all this problem. Uh, I don't know what exactly is the reason, but very rarely we come across such situation.
Yes, sir.
Right, sir. So the third question is, how common is it to have chronic iritis after pupil repair? What should be done for that? I think we've discussed the role of steroids already, sir.
Yeah. Chronic
Somebody
iritis.
want to take it up?
Yeah,
Yeah,
chronic
please.
iritis in real life scenarios, you would not come across at around 20% of all iris repairs, you come across chronic iritis. And again, it involves good pre-op evaluation to see what kind of patient it is, whether the patient is having any Urats-Zavalia syndrome or a pigment dispersion, or the patient is having a pseudo exfoliation. All these are, the other core indicators which, make you point towards the patient will have a chronic post-op iritis. Also looking at the other eye, because this eye already has trauma and you have a lot of things going on, so you might miss a small finding. But when you look at the other eye, you might pick up small things which you have missed, and that will help you prognosticate or you explain to the patient. But again, as a low dose steroid, sometimes we give Lotal LS or any kind of a low dose long acting steroid to just to reduce inflammation for a very long period of time, and you give a slow taper. Like instead of 7 days taper, you can go for a 15 days or a 1 month taper. That will reduce the iritis symptoms, and that will help in the resolution of such patients.
Just to add on to that, as Obuli said, it's very rare. You know, the reason for iris you have to know. See, why would there be iritis? First of all, because the suture that we are using, that is biologically neutral, so it's not going to cause any inflammation, or it's not going to cause any irritation. The only thing is, when you are cutting the knots, you have to be little careful. If your knot is continuously pricking the iris, then only there will be chronic iritis. If your technique is perfect, immediately there will be post-op inflammation because you have hit the iris. But once the suture tags are fibrous, there won't be any iritis. So chronic iritis, in contrast to the general perception that there will be chronic iritis because we are leaving a suture, it's not going to cause iritis. Just like tendon nylon, if you leave it lifelong, then it's not going to cause any problem. In PK patient, we leave it for 2 years. It doesn't cause any inflammation unless it is loose or pricking somewhere. So if your knot is appropriate and it's not pricking the iris, you won't have any chronic iritis. What is your body?
Yes, sir. I totally agree with whatever you said. So I think very rarely I've come across it, but I have two patients, and both of them I have kept in long taper of steroids, and both of them recovered from that also. So you come across that once in a while.
Any
So
use of NSAID? Any options of
no, sir.
NSAID rather than steroid
No,
in
sir.
such cases?
I give it as an adjunct. I don't give it as a primary therapy. I give it as an adjunct to steroids, topical steroids.
So, sir, I'll share the next question. It is, what about the riveting technique of iridodialysis repair, sir?
Very rare technique. I have been talking about the most common techniques, because if we go and there are almost at least 50 to 60 different techniques. The ease of use from the PG point of view, and the ease of reproducibility, those are the techniques which we have discussed. But there are plenty of other techniques. It's all depends on case to case basis as to what is best suited for your patient. Most of the times we end up doing either a single pass through or a hangback in real life. Other techniques, you learn about it. It is good to know if the examiner asks you to rattle it out. But apart from that, in real life things, the techniques which we have covered in today's topic is more than what you will come across in the day-to-day life.
Right, sir.
Garvita, can we know the name of the student who is asking
So,
this
Dr.
question?
Ankita here, his question on YouTube,
Well,
sir.
I think Ankita, good job. I think you must have prepared well to ask this question
Yes,
because
sir.
you
Yes, sir.
know, iris repair, there are 100 techniques.
Yeah.
Can't remember all the come prepared, and that's a good thing.
Yes, sir.
So, I'll ask the
Next
next
question,
question, sir.
Garvita.
Yes,
Yeah.
sir. Uh, Please share an artificial pupil diaphragm implant and share your experience, sir.
Sir, I have not done any implant. Have you done, sir?
I don't think, yeah.
Implant per se, you
Very
need.
rarely people have done in India. You know, the
Yeah.
problem with, hmm,
Gaurav
there is
sir,
a
you have
problem,
done
you know,
any
their
implants,
iris
sir?
color and Indian iris color that doesn't match. Yeah, so that doesn't match. And rather, at RP Center, we had
Yeah.
implanted one, and the color was in completely
Different. Yeah.
opposite to what the iris of that patient was. And so
Yeah.
he was so uncomfortable with that, we had to take it out. So
Yeah.
for Indian eyes, I don't know if any Indian company is making that. Our iris are deep dark brown and heavily pigmented. But the
Yeah.
diaphragm and iris segment which we import, those are for Caucasian eyes. Okay.
Yes, sir.
So I think very rarely people do it in India. And the complications are also very high. The pigment release that occurs from these devices, it causes intractable glaucoma. So people also avoid that.
Because the
Gaurav
patients are
sir
also
might
very,
explain.
yeah, small subset of patients who has an intact lens, whose zonules are good, and whose vault is good. All these things are there. So we come across very rarely the right kind of patient for a implant. Yeah. Next question, Garvita.
Yes, sir. So this is the last question, sir. Often seen sectoral atrophic pupil scars after phacosurgery. Is there any measure to treat? Is it usually present? Because it usually presents with complaint of photopsia.
Professor, you want to take it first?
Prevention is the best way to treat such cases.
I was about to say that.
While doing phaco, don't hit this.
Yeah. So
I
there
try
is
and
now
avoid it.
no technique or no way to this thing happen. Not to do it is the best way.
So don't hit this. That is the
Yeah.
to give him anti-glare glasses. Somehow,
Yeah.
while you're counseling the patient, tell him the
Mhm.
pros of anti-glare glasses. Then
Yeah.
you will see half of the symptom, no, they are resolved
Yeah.
because at times a psychological component is there in all these symptoms. If you counsel the patients properly, then most of the time the patient feels better after anti-glare glasses.
Yes, sir.
And with time, a lot of these patients, neuroadaptation also takes place. So these
Yes.
symptoms actually reduce with time.
Yes, sir.
So proper counseling actually helps. Like Dr. Praful said, you counsel the patient anti-glare glasses, the symptoms will go down with time.
Yes, sir.
Those were all the questions, sir.
That's good. Good to see, students preparing with all the techniques and asking us.
Well, thank you, Garvita. And yeah, so Ankita did a good job. She has come
Yeah.
prepared.
That's good.
Thank
That's a
you.
nice
Thank you,
session, sir.
everyone.
Thank you,
Great
sir.
session.
Thank you,
Thank you,
Professor,
everyone.
for moderating. Yeah.
Thank you,
Thank
sir.
you, Garvita. Yeah.
Thank you, sir.